Thank you so much for joining us. We are going to get started in 2 to 3 minutes. We have a lot of people coming in through the waiting room right now. Ooh. And for those of you who are just joining us, we're going to get started in about 2 minutes. We have people still coming in from the waiting room.
Can I see the recording later?
Yes, it's actually going to be recorded and it will be available at the latest early next week.
And how would I get it? Go on the Sharsheret site?
You can go on the Sharsheret site, but you will receive an email as a registrant with a link going directly to the recording.
Okay, thank you very much.
Sure. Thank you so much for being here tonight. I want to thank you for joining us for a really important conversation. SABCS may seem like just another entry into the breast cancer alphabet, but the annual San Antonio Breast Cancer Symposium, in its 46th year, hosts about 10,000 clinicians and scientists from all over the world and is the largest and most prestigious scientific gathering on breast cancer research. The International Scientific Symposium allows for the important interactions and exchanges between basic scientists and clinicians devoted to improved diagnosis and treatment of breast cancer. And the information that is exchanged there each year directly impacts us as previvors, as patients, as survivors. So thank you again for joining us for this really important conversation. Before we begin, as always, I have a few housekeeping items to share. First, I want to thank our sponsors, Novartis and Gilead, for their generous support of this evening's webinar. This webinar is being recorded and will be posted on Sharsheret's website alongside a transcript for you to use as a resource. Participants' names and faces will not be in the recording. Of course, you also have the option to be anonymous during today's live webinar. The instructions on how to do that are in the chat box right now. Additionally, we now have closed captions available. The instructions on how to activate that captioning is in the chat now as well. And a reminder, an important one for our Embrace community. We invite members of the Embrace community, those facing metastatic breast cancer, to stay on at the end of the webinar for an intimate conversation with our speakers and with Bonnie Beckoff, our Director of Support Services. We received an incredible number of questions through our registration process. And if there are questions that arise tonight, we will be monitoring the chat box. Please put them there and we will add them to the list of questions that we will address during our Q&A session at the end of the webinar. As a reminder, Sharsheret has been providing telehealth services to the breast and ovarian cancer communities for more than 20 years, because cancer is so much more than just a physical experience. If you are interested in finding out more about Sharsheret's free, confidential, and personalized services, please email us or visit our website at sharsheret.org. And as we move into the presentation, I want to remind you that as a national non-for-profit cancer support and education organization, we do not provide any medical advice. The information provided this evening by Sharsheret and by our speakers is not a substitute for medical advice or treatment for a specific medical condition. You should not use this information to diagnose or treat a health problem. As always, seek the advice of your physician or qualified healthcare provider with any questions you might have about your own medical condition. We are so very fortunate to have our two speakers with us today. Dr. Natalie Klar is an academic breast medical oncologist at the Perlmutter Cancer Center at NYU Grossman School of Medicine. She received her medical degree from Albany Medical College, where she graduated cum laude and was inducted into the Alpha Omega Alpha Honor Society. She attended her internal medicine residency at the University of Pittsburgh Medical Center. She has over 5 years of clinical and research experience in breast oncology, and her goal is to personalize treatments based on her patients' tumor biology and immunologic infiltrates while keeping their cultural views and personal preferences in mind. Her clinical research interests include triple-negative breast cancer, immunotherapy, and health equity. She has presented her research at many prestigious medical conferences, including San Antonio. She has published original research and reviewed articles in Clinical Breast Cancer, the Journal of the National Cancer Institute, Breast Cancer Research Treatment, and the Breast Journal. Dr. Klar, we are so happy to have you here today. Thank you very much.
Thank you for having me. I'm going to just share my slides here. Let's see. You guys see it in slideshow mode or not yet?
Not yet.
Okay. Let me see.
Right, you should just hit from the beginning and that should get it there. Under slideshow, there.
You see it that way or?
No.
No.
Oh,
Okay.
yes, now we do.
Okay. So in terms of, thank you for the introduction. So I'm going to review, I'm a medical oncologist at, breast medical oncologist at NYU, and I'm going to review some of the medical updates from San Antonio. So to start out, I have no financial disclosures, but one of the studies I'm going to talk about, the positive trial, I am one of the study authors on the trial. So an overview of the studies I want to discuss tonight. I want to discuss the positive trial, which I am one of the study authors on, which is a study looking at pregnancy after the breast cancer diagnosis. And this is an update looking at the use of assistive reproductive technology. I also want to discuss another study, the preferable effects study, which is a study looking at structured exercise programs in metastatic breast cancer patients and the impact on quality of life, fatigue, and other cancer-related outcomes. The third study I want to discuss are the updated results from the Catherine study. And this was a study presented several years ago, but they have an update in their results. And this is a study looking at TDM1, which is also known as Kadcyla, compared to trastuzumab Herceptin, used in the adjuvant setting for stage 2 and 3 HER2 positive breast cancer. And the fourth study I wanted to discuss was an updated result from the KEYNOTE-522 study, which is a study looking at the addition of immunotherapy, pembrolizumab, also known as Keytruda, in addition to chemotherapy, compared to chemotherapy alone in stage 2 and stage 3 triple-negative breast cancer. And so the first study I'm going to review is the positive study. So this update on the positive study is looking at fertility preservation and assisted reproductive technology in breast cancer for women who interrupted their adjuvant endocrine therapy. So the positive trial is a prospective international multi-center investigator initiated single-arm trial. This study included women who have the diagnosis of hormone-positive breast cancer, and these women underwent their breast cancer-related surgery, chemotherapy if indicated, radiotherapy if indicated, and then received at least 18 months and up to 30 months of adjuvant endocrine therapy. Then if these women chose to enroll in this study and were interested in a pregnancy, they paused their endocrine therapy for up to 2 years to allow time for conception, delivery, and or breastfeeding, and then needed to resume their endocrine therapy at the 2-year time point, and then to complete 5 to 10 years of endocrine therapy based on their decision with their physician. And then these women are going to be followed for 10 years following that. In terms of key eligibility, these were premenopausal women with stage 1 to stage 3 hormone-positive breast cancer. These were women who wanted to become pregnant. These were women who were 42 or younger at study entry. These were women who had at least 18 months of endocrine therapy, but no more than 30 months of endocrine therapy before joining the study. And these were women who had no clinical evidence of recurrent disease. So the primary endpoint of this study was breast cancer-free interval, and this was presented at San Antonio in 2022, so last year. And the data showed that overall there was, at the 3-year time point, there was no difference in breast cancer-free interval for the women who paused their endocrine therapy to attempt to have a pregnancy versus the women who, women compared to the general population of women who usually do not pause their endocrine therapy for 2 years. So this presentation at San Antonio this year was looking at 2 things: menstruation recovery, as well as use of assisted reproductive technology. And what they did was they collected information on the patients enrolled in this study. They were asked to keep a menstrual diary for 2 years. They were asked if they used any fertility preservation at the diagnosis of their breast cancer. And if they did, that information was collected. And if they used any assistive reproductive technology, while they were on the study, that information was collected as well. And so this study had 516 patients. 66% of the patients were 35 or older. 34% of the patients had a positive lymph node. 62% of the patients had prior chemotherapy. And 75% of the patients had not had a prior live birth. So in terms of menstruation, so as some of you may know, when you receive chemotherapy, and 66% of the patients, in the study had received prior chemotherapy, that can affect the ovary, so that can affect fertility, and that can also affect the ability to continue menstruating. So a lot of times the menstruations are interrupted. So at the enrollment of this study, 53% of the patients had amenorrhea, even though these are young women. The good news was 94% of the patients had a recovery of their menses. And at the 6-month time point, it seemed that almost about 90% of the patients were having menses recovery. You can see on this graph that the green line was patients who received chemo with no GnRH, and those had a lower rate of their menses recovering at 6 months. And GnRH you might know as Lupron or Gosrelin. Those are medications that sometimes are given with chemotherapy to protect the ovaries and prevent amenorrhea or early menopause from happening. In terms of time to pregnancy, the good news was 74% of these women had at least 1 pregnancy. The biggest factor associated with having pregnancy during these 2-year time point was age. And so you can see the women under 35 at the 24 months, 80% of them had a pregnancy. You could see in the blue line, the blue dotted line, the women 35 to 39 were somewhere in the middle. And the lowest rates of pregnancy were in the women who were age 40 to 42. But still at 24 months, 50% of those women were able to have a pregnancy. And then they looked at the data on using assistive reproductive technology. 51% of the patients did some form of fertility preservation at the time of their breast cancer diagnosis. 36% of the patients had ovarian stimulation for embryo or oocyte cryopreservation, sometimes known as embryo or egg freezing. In terms of assistive reproductive technology, 43% underwent some form of assistive reproductive technology at enrollment on this study, 16% of the patients had ovarian stimulation for IVF, and 14% of the patients had cryopreserved embryos transferred. And the data of using this technology with chances of pregnancy, as we discussed before, as age increased, the chances of pregnancy went down, with the lowest rates of pregnancy in the older women on the study, the 40 to 42-year-olds, compared to the women under 35. The thing that made the chance of pregnancy the highest was actually using a cryopreserved embryo compared to not using any assisted reproductive technology, with an odds ratio you can see there of 2.41. And they have a little asterisk, and you can see 82% of the patients who had a cryopreserved embryo transferred had at least one pregnancy while on study. And then they looked at the use of this ovarian stimulation and this embryo oocyte cryopreservation at the time of breast cancer diagnosis, and if this increased the risk of breast cancer events occurring. And at the 3-year time point, there's no significant difference in rates of breast cancer events occurring. You can see there's a difference of 9.7 versus 8.7. It's a 1% difference, but it wasn't statistically significant. And you can look at the graph here and you can see the blue line for the women who did the embryo oocyte preservation and the dotted line for the women who did not do it. You can see those lines are pretty similar. So there's not a big difference in terms of breast cancer outcomes at the 3-year time point. They then looked at the women who used assistive reproductive technology and ovarian stimulation while they were on the study. And you could look at the two lines, the dotted line and the solid line, and they look fairly similar. And there was not a big difference in the number of breast cancer events at the 24-month mark between these two groups. So overall, the conclusion of this study is it's a large prospective study looking at fertility preservation and ART in patients with early stage hormone positive breast cancer who desire pregnancy. 90% of the women presented with who had amenorrhea resumed their menses. Young patients in young age was the main factor associated with shorter time to pregnancy. Embryo and oocyte cryopreservation at breast cancer diagnosis, followed by an embryo transfer, had the highest rates of pregnancy and was not associated, at least at the 3-year time point, with worse prognosis from the breast cancer. There was no increase in breast cancer events for women who underwent IVF, but we need longer term follow-up. And this data is really important as we counsel our young patients about oncofertility and interest in how to stay fertile and have a pregnancy after they undergo treatment for their breast cancer. And it'll be important to watch this data over time, because right now we only have the data at the 3-year time point. And as we're discussing, these are very young women, and 70% of them just had a baby. We don't want their breast cancer to reoccur at the 3-year time point, nor do we want it to reoccur at the 5, 10, 15, 20-year time point. So we're going to have to watch this data over time. The next study I wanted to talk about was the preferable effects study presented by Dr. May at San Antonio. And this looked at the effects of a structured exercise program and for metastatic breast cancer patients and how it impacted fatigue and health-related quality of life in these patients. And this study had 350 metastatic breast cancer patients. They were either randomized to a 9-month structured and personalized exercise program that included aerobic training, resistance training, and balance training. This program was twice a week for 60 minutes. Or they were in a control group that was just their usual care and just general advice from their doctor that it's good to exercise. And you can see here in the graphs, the yellow-orange line represents the women who were in the exercise group, and the exercise group patients had higher quality of life scores and lower physical fatigue scores compared to the women who were just in the general standard of care group. And so the conclusion is that this structured resistance and aerobic exercise program resulted in beneficial effects on fatigue, health-related quality of life, and other clinically relevant outcomes in metastatic breast cancer. And hopefully there'll be more programs like this offered to patients as it seems to have a really good effect on helping patients with fatigue, quality of life, shortness of breath, pain, and some other symptoms that metastatic breast cancer patients have. The next study I wanted to discuss was the updated results on the Catherine trial. So the Catherine trial was a study in stage 2 and stage 3 HER2 positive breast cancer patients. And this was a study that looked at giving the standard of care for HER2 positive breast cancer patients is receiving chemotherapy as well as HER2 antibodies such as trastuzumab, Herceptin prior to surgery. And following that treatment, patients go to surgery. And at time of surgery, we can tell if patients had a complete response based on their pathology from their surgery, meaning no cancer is left, or if they have residual disease, meaning there is still some cancer remaining. And for the patients who have residual disease, they're at higher risk for their breast cancer to come back. So this Catherine study looked at giving a newer medication at the time called TDM1, Kadcyla, for 14 cycles compared to giving the standard, which was just trastuzumab, Herceptin. And when this study was first presented back in 2018, they showed these graphs here. And in terms of invasive disease-free survival at the 3-year time point, if you had received just TDM1, the invasive disease-free survival was 88.3%. And if you received trastuzumab, the invasive disease-free survival was 77%. And with this benefit, you can see the difference graphically too between the blue and the orange line. This was approved, and this became kind of the standard for residual disease in stage 2 and 3 HER2 positive receiving Kadcyla TDM1. And you can see here back in 2018 when they presented, they also looked at the overall survival, but the two graphs weren't very different, at least at this time point. And so they weren't able at that time point to see a significant difference in overall survival. So they represented the data this year at San Antonio. And you can see here at the 7-year time point, the blue and the yellow-orange line are actually still very separate. And the difference is 80.8 versus 67.1 in invasive disease-free survival, which means that there's an absolute invasive disease-free survival benefit of 13.7% at the 7-year time point. They then showed the data for the overall survival. And in terms of the overall survival, you can see at the 7-year time point, we now see these two graphs, the blue and the orange, starting to separate a little bit more. And you can see that the absolute overall survival benefit at 7 years is 4.7%, which is a significant reduction in the risk of death by 34% with the TDM1. And so the conclusion is that there's a significant benefit at the 7-year time point for invasive disease-free survival with an absolute benefit of 13.7%. And now we're seeing a very significant overall survival benefit at the 7-year time point of 4.7%. So this is a med that we've been using for the past several years for our patients. And this is good news to see that there's still lots of benefit years later after completing the treatment at the 7-year time point. And that the benefit extends to overall survival as well. And the last study I wanted to review is the updated results that was presented at San Antonio for the Keynote 522 study, which is a study in stage 2 and stage 3 triple negative breast cancer. And in this study, the standard of care for stage 2 and stage 3 triple negative breast cancer patients is receiving chemotherapy before surgery. In this study, patients either receive the standard of care chemotherapy before surgery, or they receive the standard of care chemotherapy plus an additional immunotherapy called pembrolizumab or Keytruda. And if they receive the pembrolizumab before surgery, they also receive the pembrolizumab after surgery. And this data was presented at the 36-month time point, and they saw a difference between 84.5% and 76.8% in event-free survival. You can see the difference between the green and the brown lines on the graph. And this led to the FDA approval of pembrolizumab in this setting. And for the past, year and a half, 2 years, we've been using pembrolizumab based on this FDA approval and based on this EFS benefit. So the updated results were presented at San Antonio, and this is on the other side of the screen showing the 60-month update. And at 60 months, we're seeing the graphs are still separate, and you see 81.3 versus 72.3 with the same hazard ratio of 0.63. They then showed some more data, and they divided it by patients with different stages. So for the patients who had stage 2 disease and the patients who had stage 3 disease, we can still see the graphs are separate. And they looked at two different groups, the patients who their cancer completely went away when at the time of surgery, calling PCR, and the patients who did not have a PCR and still had some residual cancer at the time of surgery. And you can see the lines are more separate for the patients who did not have a PCR, a difference on the stage 2 side of 69.2 versus 59.1, and a difference on the stage 3 side of 46.8 versus 38.2. However, what's interesting is even for the patients who the cancer completely went away, the PCR group, we are seeing a difference between the lines for the patients who received the pembrolizumab. They then showed the same data for the patients who entered the study with a positive lymph node and a patients who entered the study with a negative lymph node. And as you can see, the graphs look pretty similar as well. And we see a benefit kind of in both these groups. So overall, this updated data shows that at the follow-up of 5 years, we're seeing clinically meaningful improvement in event-free survival for patients who received pembrolizumab in addition to their chemo. And this benefit's seen in the stage 2 patients and the stage 3 patients. This benefit's seen in the node positive and the node negative patients. And interestingly, we're seeing the benefit in the patients who had the complete response and as well as the patients with residual disease. So it's very interesting, and we've been using pembrolizumab since it was approved a year and a half ago, 2 years ago, based on the previous data. But it's good to see that the data continues to show that all groups are benefiting from this medication being added to chemotherapy. And I think those were the studies I wanted to review for today. So I think we could kind of move on to the next presentation, and I'll take questions afterwards.
Right. Can you unshare your
Yes, I'm going to stop
screen?
sharing right now.
Right. And before you go, there was one question. There was one question that was very specific to one of the studies. The others that I noted were a little more general, but somebody asked about, with the first study, the cryopreservation was always done before treatment in the positive study?
I think the majority of the cryopreservation was, typically we recommend if you are receiving chemotherapy, there's a chance that that's going to impact your ovaries and your fertility. So typically we recommend, if you're interested in a pregnancy and you are interested, sometimes thinking about doing the cryopreservation before you undergo chemotherapy. In the study, they only talk about the rates of cryopreservation being done before starting endocrine therapy and before chemotherapy. They don't talk about the rates afterwards. But yeah, that is an interesting question, because sometimes in clinic, we see patients who didn't have the opportunity. They were in a rush to get started on their chemo or other things. Sometimes there's also financial barriers as well. I see in the chat, someone just said, yes, so they kind of lumped both the egg, because the oocytes that you were seeing, that's eggs. So they lumped the embryos and the oocytes together in some of the data. And then other data, though, when they talked about the highest rates of successful pregnancies, those were with the frozen embryos. And that has been known that embryos are a little bit more successful because it's kind of a combined egg and a sperm and a full embryo. So they're a little less fragile and they're a little more successful at when they undergo the unfreezing process and implantation process of being successful. Yes.
So there are a lot more questions that came through, but they're a little more general. So we're going to save them for the Q&A. I want to thank you. Those are for really, hope-giving studies, and we'll talk a little bit more about them shortly, but thank you very much. Now, I want to say we also have with us Dr. Namit Gerber, who is the Vice Chair for Education and an Associate Professor in the Department of Radiation Oncology at the Perlmutter Cancer Center of the NYU Langone Medical Center. Dr. Gerber received her AB in the History of Science from Harvard College and her MD from the Icahn School of Medicine at Mount Sinai. She completed her residency in radiation oncology at Memorial Sloan Kettering. Dr. Gerber specializes in the treatment of breast cancer and lymphoma. She is the co-leader for the disease management groups for breast cancer and hematologic malignancies at the Perlmutter Cancer Center. In addition to her clinical practice, she's actively engaged in research that focuses on Improving Outcomes for Women with Early Stage Breast Cancer. She's authored over 50 peer-reviewed publications. Dr. Gerber also serves as the program director of the NYU Radiation Oncology Residency Program. Thank you for being with us and welcome to the screen.
Thank you so much for having me. I really appreciate the opportunity to speak to all of you tonight. Okay, so I'm going to go through a few studies from San Antonio. And in order, here are my disclosures. I received research funding from Prelude and consulting fees from Accuray. In order to place some of these studies in context, I'm actually going to start with the Prime 2 publication, which came out in the New England Journal of Medicine just a little bit less than a year ago, which really sets the backdrop for the IDEA trial, which was presented at San Antonio this year. And both of these studies are looking at the omission of radiation in early stage breast cancer patients. We're then going to shift gears to talk about women who were treated with neoadjuvant chemotherapy, similar to the paradigm of the Catherine trial that Dr. Clark just spoke about. And this was a trial that until San Antonio this year, we knew nothing about its results. This was the first time we have results, so it's very exciting, and I'll share those 5-year results with you. And then finally, I'm going to touch on a study that was presented at San Antonio that looked at outcomes in women with BRCA1 mutations based on the type of surgery they had. Okay, so this is a slide which was from the Lancet 2011, which was really demonstrating this paradigm that when women have a lumpectomy, meaning they preserve their breast, they do not have a mastectomy, and then they get radiation, that radiation is not just lowering the risk of any recurrence, but it's actually improving the risk of breast cancer mortality, of dying from breast cancer, and it's improving overall survival. And ever since the publication of this meta-analysis, this has really been the paradigm within radiation oncology and early stage breast cancer, that when we give radiation after a lumpectomy, we're not just lowering the risk of recurrence, but we're saving lives. But our field is always asking, are there women who don't need radiation? Are there women in whom they can still get a lumpectomy and still be spared radiation? And so for years, we've been trying to identify a group of patients who might fall into this category. One of the early trials that was done in this space, which was viewed as a success, was this study, which looked at women 70 years or older with stage 1 estrogen receptor positive breast cancer. And these women were randomized to tamoxifen alone. This was before aromatase inhibitors. So they all got tamoxifen versus tamoxifen and radiation. And what this study showed was that radiation, which is the women in blue, are still doing better, but that the women who get the tamoxifen alone are still doing okay with only a 10% recurrence, and that most of these women were thankfully not dying of their breast cancer. And there was no difference in mastectomy-free survival or overall survival. And so this study really set the stage that maybe in women over the age of 70, if they're going to get 5 years of tamoxifen or an aromatase inhibitor, maybe they don't need radiation. And then came the Prime 2 trial, whose 10-year results were published in the New England Journal just less than a year ago. And this lowered the age group to 65 years old. It included women with tumors up to 3 centimeters who were lymph node negative, with hormone receptor positive breast cancer, negative margins. And very similar to the CALGB trial, they showed that radiation was still, lowering the risk of a local recurrence. Here's the blue line versus the red line. But it had no effect on overall survival or breast cancer specific survival. And that most of these women were not dying of their breast cancer. 13% of the deaths were due to breast cancer. Interestingly, in the Prime 2 publication, when they separated out the estrogen receptor positive patients into those who were strongly estrogen receptor positive versus those who were more weakly estrogen receptor positive, there was a higher risk of recurrence in those who were estrogen receptor low, showing that maybe we should not omit radiation in those women. And then they also looked at the risk of recurrence in women who were not able to take 5 years of the endocrine therapy for whatever reason, and showed that in the women who did not finish their 5 years of endocrine therapy and did not get radiation, the risk of recurrence was almost 5 times as high. So the takeaways from this publication that, perhaps we can lower the age to 65 for women who might not all need radiation. In these women, radiation is still working, though. It's reducing the local recurrence from 9.5% to essentially 1%. No difference on survival in this small group of patients, in this group of patients over 65. They had very few patients who had grade 3 disease or lymphovascular invasion, so this does not apply to all women with early stage breast cancer. It might not apply in women who are estrogen receptor low. It certainly is not applicable for women who aren't able to tolerate 5 years of endocrine therapy. But radiation can be safely omitted in women 65 years or older with grade 1 or 2 estrogen receptor high cancers if they are going to tolerate 5 years of endocrine therapy. We know that radiation is still working in this patient population and providing more than a 10-fold reduction in local recurrence. We don't always know who's going to tolerate the 5 years of endocrine therapy. And then finally, we know that thankfully with shorter courses of radiation that we have now, as short as 1 week, maybe there are women for whom radiation would provide a better risk-benefit ratio than endocrine therapy. And that's an area of ongoing study in the Europa trial going on in England and in Europe now. So this is very similar to this trial that was just presented in San Antonio, the IDEA trial. What was novel about the IDEA trial and what's novel about many of the ongoing trials right now in this, early stage breast cancer space is they're lowering the age from 65 or 70 down to 50. And then they're using genomic markers to try to better select women who might not need radiation. So in this case, they're using the Oncotype score, which is a score, as many of you know, that we use for chemotherapy decision-making. So women who have, stage 1 breast cancer with a low Oncotype are being randomized. This trial was a single arm. They got 5 years of endocrine therapy and no radiation. The mean age was 62. These were women generally with small tumors, about 1 centimeter, low Oncotype scores, a mean of 11. A third of them had MRI. They were strongly estrogen and progesterone receptor positive. And very few grade 3 patients, only 3%. At a median follow-up of 5.2 years, they had overall in breast cancer specific survival of 100% with 5-year freedom from any recurrence of 99%. 2 patients had recurrences before 5 years. 6 additional patients recurred later than 5 years. No distant recurrences. They did look at compliance with endocrine therapy with tamoxifen or aromatase inhibitors. The patients who recurred before 5 years were taking endocrine therapy, but 3 of the 6 of the patients who recurred after 5 years were compliant and 3 of 6 were not compliant. These are the curves just showing the excellent outcomes in these patients. And these are some of the other ongoing trials, which are looking at, omission of radiation in women generally over age 50 or over age 55. Some are a little bit older. The Primetime trial is 60. Europa is over 70. These are all stage 1 patients who are estrogen receptor positive. Most are grade 1 to 2. And most are now using some form of biological selection, whether it's the Oncotype or the PAM50 score, to really identify these lowest risk patients and are testing whether or not all these women really need radiation. This is the DEBRA trial that we've opened at NYU right now. Similar idea, age 50 to 70, recurrence scored less than 18, and randomized to radiation plus endocrine therapy versus endocrine therapy alone. So just to conclude this part of the talk, this is very exciting work that maybe we don't need to give radiation to all of our patients. Right now, we have published data for women 65 or older with small, strongly estrogen receptor positive breast cancer. And again, sort of the importance of us also looking at maybe can we de-escalate endocrine therapy, which of course has its own side effects, and give radiation in these women, which this Europa trial is looking at. And we need the results of all of these prospective trials that are using biology to determine the benefit of radiation. Okay, so now shifting gears to women who get neoadjuvant chemotherapy. And this is, again, sort of the first time we've seen results from this large trial that is an NRG, and a national cooperative group trial. So what this trial was looking at is, we know that in women who have positive lymph nodes up front, that there's a small benefit of getting not just radiation to the breast, but also radiation to the lymph nodes, meaning the lymph nodes that sit in the axilla and the armpit, above and below the collarbone. But when we started treating patients with chemotherapy before surgery, with neoadjuvant chemotherapy, And patients had positive lymph nodes before chemotherapy, but then at the time of surgery were found to have a complete response. We didn't know if those patients need radiation to their lymph nodes. We had no data in that space. And that was what this trial was trying to answer. So it's taking women who have positive lymph nodes, who get neoadjuvant chemotherapy, and at the time of surgery have no cancer left in the lymph nodes. And it was randomizing those patients to either get regional nodal irradiation or no regional nodal irradiation. Women who had lumpectomies in the no regional nodal irradiation still got radiation to their breast versus the breast plus the lymph nodes. And women who had mastectomies either got no radiation at all versus comprehensive radiation to the chest wall and the regional nodes. They accrued 1,641 patients. We have this open at NYU and we're accruing at NYU. The median follow-up time at this time of this report is 5 years. This is the women in the trial. You can see a real distribution in age, young age, older age, distribution of race, clinical tumor size, a good representation of triple negative, hormone receptor positive, HER2 negative, hormone receptor positive, HER2 positive. About 60% had lumpectomy, 40% mastectomy. Not all of the patients had a complete response in the breast. About 80% did. They all had to have a complete response in the lymph nodes as a criteria for being on this trial. And you can see these curves are overlapping. There was no benefit of treating the lymph nodes in these patients. Similarly, there was no benefit looking just at local regional recurrence. You definitely see when you break down the numbers that in the regional nodal irradiation arm, there were fewer recurrences in the lymph nodes, right? It's 8 versus 0. But as a statistical matter, there was no statistical difference between these groups. And then when they looked at the subgroups, just to point out a few sort of interesting things, maybe a little bit more of a benefit in the mastectomy patients, maybe a little bit more of a benefit in these estrogen receptor positive, HER2 negative, and less of a benefit in triple negative. That was statistically significant. But all in all, for patients who present with biopsy-proven axillary lymph node involvement and become lymph node negative after chemotherapy, regional nodal irradiation does not improve outcomes. And there are many advantages to neoadjuvant chemotherapy, right? You can shrink tumors, allow for less surgery, either to the breast, also to the axilla, maybe not need an axillary lymph node dissection. And now we can add another thing to that list, that if women get neoadjuvant chemo and have a complete response, many of these women can be spared larger fields of radiation, or in the case of mastectomy, they can be spared any radiation at all. Now, I should note that we do not yet have the publication of this data, and there will be 10-year data. So we're not applying this sort of in a black and white way in clinic yet. We're still talking to a lot of these patients, making very individualized decisions, but this is very exciting data that maybe some of these women can be spared the regional nodal irradiation. Okay, and then finally, just to touch on this study that was presented on BRCA1 mutations in surgery. This was a study whose goal was to look at the risk of contralateral breast cancer in women with BRCA1 pathogenic variants, so not like a variant of uncertain significance, but that it was known to be a pathogenic variant. Breast cancer stage 1 to 3, they excluded DCIS or stage 4 breast cancer. This was a very large study, so it was 2,482 eligible participants from 26 centers in 11 countries, diagnosed from 1995 to 2021 with a median follow-up of 9 years. About 42% of patients were less than age 40. And then this is the breakdown in the surgeries. So 34% had breast conserving therapy, so lumpectomy. 46% had mastectomy in just the affected breast, and about 20% had a bilateral mastectomy. When they looked at differences between the groups, you can see some slight differences. The bilateral mastectomy patients tend to be diagnosed later. The younger patients were more likely to get bilateral mastectomies. And then this is their outcomes. When they looked at contralateral breast cancer, they saw higher rates, not surprisingly, in the patients who had either lumpectomy or unilateral mastectomy, with the lowest rates in the patients who had bilateral mastectomy. When they looked at patients who died of breast cancer, this is unadjusted for other factors. We're going to get into a better analysis in a minute, but just looking just at the differences here, you see lower rates in bilateral mastectomy, and then, you see the higher rate of dying of breast cancer in the unilateral mastectomy with lower rates in bilateral mastectomy and in the breast conserving surgery arm. But also very important to note that the bilateral mastectomy patients were more likely, so if you look here at the positive lymph nodes, unilateral mastectomy patients were more likely to have positive lymph nodes and some other higher risk features. They also looked at other factors like who got oophorectomy, radiotherapy, chemotherapy, and tamoxifen. This was looking at contralateral breast cancer. I already showed the numbers, but to show it on the graph, with the lowest rates in gray here are from bilateral mastectomy, and similar rates in lumpectomy and unilateral mastectomy. This was looking at breast cancer mortality with the higher rate in the unilateral mastectomy patients and lower rates in lumpectomy and bilateral mastectomy patients. Now, this is important because this is where they start adjusting for the other factors, right? So the fact that some women were coming in higher risk in the unilateral mastectomy arm. And here, when they looked at all patients, they did not see any differences on multivariate analysis when they accounted for the other factors, meaning when they saw this higher rate of breast cancer death in the unilateral mastectomy patients, that did not hold true once they adjusted for factors. And that was true both in women less than 40 and more than 40 and greater than 40. So just to conclude this section, most common surgery among women with BRCA1 mutations in this very large international cohort was unilateral mastectomy, followed by breast conserving therapy and bilateral mastectomy. There is a higher risk of contralateral breast cancer when women undergo breast conserving surgery and unilateral mastectomy as opposed to bilateral mastectomy, with no difference in mortality between the breast conserving surgery and the bilateral mastectomy. And then when they adjusted for other factors like age, nodal status, and other treatments, they had no difference in breast cancer mortality with any surgery subtype. So I just want to thank Sharsheret for organizing this webinar and inviting me to take part. So many of my patients, benefit from the services Sharsheret offers, and it's really so wonderful that, everything that you do. And I want to thank my research collaborators, my clinical team, and all the patients who have participated on these and many other clinical trials without whom we would never be able to advance our knowledge and our science. So we really appreciate participation. Thank you.
Thank you so much. That was also a lot of very hopeful information. I'm gonna bring, this is very difficult for the layperson to understand in general, all of these things. So there are a lot of questions, and I am going to bring Dr. Clark up here as well. A lot of the questions focused specifically, it's a good question too. A lot of the questions focused specifically on determining when a recurrence does happen. So some of these questions are study specific that you presented, and some we're just hoping you learned other things at the conference that you can share with us. So are there any new and reliable markers to trend for disease recurrence? In other words, what type of surveillance should be happening? What about the new blood tests? Are they accurate at this point? For people who have had bilateral mastectomies, perhaps had oophorectomies or hysterectomies, like how are there ways for us to check to see if there are recurrences in other parts of our bodies? And I'm gonna let you both decide who's gonna talk.
I can start with this one. This is a great question. It comes up a lot. So for breast cancer, the screening guidelines for all the different subtypes of breast cancer for stage 1, 2, and 3 breast cancer is not to do systemic scans, so not to do CT scans or PET scans, and because that's the guideline, that means insurance companies might not also cover it. And not to do blood tests, like there's the old-fashioned tumor markers you might have heard that are very non-specific. It's like a lab test for like CEA or a cancer antigen 2729. Those are not very specific necessarily for breast cancer, but different types of cancer in general. And the guidelines are not to do these tests and to just do breast imaging which is usually done ordered typically by the breast surgeon. And based on your risk, determine breast imaging. But like you said, if patients had bilateral mastectomies, it's just clinical exam. And if you have a symptom, you let us know. And if you have back pain, then we scan your, then we do a scan of the back, et cetera. But of course, we take care of young, healthy patients, and we want to catch disease earlier. So I think the question on, can we get a good test for this, is a great question. And there are some new tests, and I think some people are alluding to them, which are called like cancer tumor ctDNA, which is cell-free tumor DNA. And sometimes they take a sample from your breast cancer surgery or your biopsy and a sample from your blood, maybe at the time of diagnosis, and then they follow your blood over time to see if any of those cancer cells ever come back positive. Right now in breast cancer, it's a little bit hard. There have been no large randomized studies to say exactly what to do for the data. There have been small studies showing that if it does become positive, and then we scan a patient, about 30% of the time, we're going to find a spot that we then biopsy and it's cancer. And 60% of the time, we're not going to find anything. But if we follow that patient over the next several years, they're a higher risk for something popping up. So right now, that's kind of where we are. And so most academic breast oncologists aren't doing this test routinely because we don't exactly know what to do with the information, and having an extra test that can add stress and it's not necessarily clear what to do.
So you're saying we're still not there yet?
But the test is available, and there probably are some doctors who are running it. I would say the best way to do this test is to do it in a randomized clinical trial. Right now at NYU, we don't have any opened. I think we're working to try to have some. There might be other sites in the country that do have some of these randomized clinical trials. And other clinical trials, if patients enroll on a clinical trial for something else, sometimes this is one of the things that they're collecting in their blood tests and in their follow-up visits. And so hopefully in the coming years, we're going to have more data on this. But right now, like if you have friends or family who have colon cancer, right now they're making treatment decisions and using it. There's more data in colon cancer and other types of cancer. Right now in breast cancer, it's a little bit unsure. And just because the test exists and it sounds really promising and a great idea, it's a little hard because we're in this area where we don't exactly know what to do. So I would advise patients to maybe, have ctDNA done in the setting of a clinical trial where it's controlled and it clearly tells, the doctors what to do. But in the general setting, occasionally we'll do it on a case-by-case basis, but we're not generally doing it on all our patients.
Okay. All right. Maybe next year's update we'll have better information.
Yeah, hopefully.
A couple of other questions. Any information shared about the clinical trials with regard to vaccines to prevent a diagnosis? I guess not. Okay. So we'll hope for that for next year too. Okay, this one is for Dr. Gerber specifically, which is, when will AI use in mammography become the standard?
Yeah, great question. So it's definitely an area of emerging research with the the preliminary results very promising in terms of the way that AI is improving diagnosis. And I think many radiology departments are already sort of incorporating elements of AI into into their diagnostic protocols with radiology input. So I think it's happening, and there's emerging research showing that it's helping with diagnosis.
Thank you. A different type of AI. So are there any new drugs in the pipeline that might replace tamoxifen, aromatase inhibitors with fewer side effects and less toxicity?
Oh, so there's some medications called like oral SERDs. It's a class of medications. There was a medication approved within the last year or so, elacestrant, but that is approved in the metastatic setting. So right now there's no newer meds in terms of the early stage settings. There's studies now, and patients might hear like medications like abemaciclib is used in the early stage setting, but that's in addition to the endocrine therapy. And there's a medication called ribociclib or Kisqali that also is right now only used in the metastatic setting, but more data is coming out, and that might at some point get approved to be used in addition. But in place of those endocrine therapies, right now we don't have anything. However, some of these medications that are being used now, like I mentioned, elacestrant is and some of these other oral SERDs and other medications are being used in the metastatic setting, they might, they're going to probably, we've had some studies opened at NYU being tested in the early stage setting.
Oh, that's interesting.
And so, however, nothing is without side effects. So unfortunately, and every patient's different. So there's a chance that maybe some patients do better on tamoxifen versus on anastrozole, and some patients might do better on these. But I think, unfortunately, it seems like all these medications will have some side effects for some patients.
So as long as we're talking about aromatase inhibitors, any updates on the 5 versus 10 years of endocrine therapy?
I don't think there were any updates this year at San Antonio. What was interesting, actually, last year they did like a poll, like they poll the audience sometimes with questions. And one of the polls last year, I think at San Antonio, was they were asking how often do doctors send any tests or any testing to make the decision of 5 years versus 10 years. And it was an international crowd, and it was actually pretty low percentage of doctors who answered, and scientists there who actually were sending additional testing to determine 5 or 10 years. So it'd be interesting if they polled the audience again, if that, over the past few years, if that's changed. There's certain tests that doctors can use, like there's the breast cancer index is one of them. And that's a test where it's a test on the tumor surgical sample, and you get results based on the tumor genomics on whether or not they think there's a significant benefit of extending the endocrine therapy. So that's interesting that right now, at least when they polled 2 years ago, the majority of people weren't yet using the test, but that is an extra data point to help make that decision for the patients and their doctors.
Thank you for that. Okay, somebody asked, with regard to the studies you were talking about, Dr. Gerber, did the studies look at photon or proton radiation therapy? And before you even answer that question, can you explain the difference?
Sure. So most of the radiation that the vast majority of radiation oncology centers in the United States and in the world offer is photon radiation. Photons are just high energy X-rays, which are typically delivered with a linear accelerator, external beam radiation. Protons is also external beam radiation. It's a charged particle. It's with protons. There are fewer proton centers throughout the United States. For breast cancer, not almost, all of these studies were using photon radiation, so X-rays. There is an ongoing, very large national study comparing protons and photons for breast cancer, for lymph node positive breast cancer, and we're awaiting these results. The main endpoint of this study is seeing if with protons we can lower the dose to the heart. Until this study results, the standard of care for breast radiation is photons. There is no indication at this point off of a clinical trial for protons, meaning that no one needs to get protons for breast cancer, and we don't even know if they're beneficial yet.
Okay, thank you. 2 more questions. We're going to try and keep the answers real quick. Were there any conversations in San Antonio about treatments, any type of treatment, aromatase inhibitors, chemo, radiation, and the use of THC to manage side effects? No. Okay.
I don't think so.
Not that I'm aware of.
Okay. All right. It was a good question. And somebody asked, and this is a great question to end with, somebody asked, if we want to learn more about a particular study, where can we go to learn about these studies?
Yeah, that's a great question. So, some of these studies are publicly available in their original form, but, for someone who's not necessarily in the science world, it sometimes is, hard to sort of read through the original results. ASCO, San Antonio would put out press releases. So, if you can sort of find on Google the press release from San Antonio, that often sort of has some commentary and is sometimes more in a lay language. And then there's also a publication called the ASCO Post, which is, from the American Society for Clinical Oncology, and they'll often summarize major studies. And I don't know if they've already done it, but they'll often do it in addition after San Antonio summarizing these studies. And again, there's some commentary. It's a little bit more of a lay audience. So those are just some of the more, very reputable and scientific sources, but hopefully a little bit more digestible than just reading the original study.
Amazing. We'll include that information in the follow-up email that goes out. I want to take a second to thank both of you very much for sharing your knowledge, your expertise with us. There was a lot of hopeful information here, and it's clear that we're hoping for even more hopeful information next year. They're not going anywhere yet, but I just wanted to take a second to share a little bit more information before we segue into our Embrace group. Again, those of you who are impacted by metastatic breast cancer, who are planning on staying on for this additional conversation, please stay where you are. And as the main part of the webinar concludes, Bonnie will begin the breakout session. So again, thank you to our doctors for joining us tonight. A lot of great information. Thank you to Novartis and Gilead for their support of tonight's program. Please take a moment to fill out the brief evaluation survey that's in the chat box right now, and you can click that and still listen to the rest of the webinar. And if you're staying for the Embrace breakout, that link will be given one more time. Again, somebody just asked about a recording. A recording of this, a video recording of this webinar and a transcript will be available next week. And as soon as those are available, everyone who's registered will receive an email with a link. Finally, I want to let you know that we have our annual genetics webinar scheduled for Tuesday, January 30th. This year's topic is navigating the conversation of inherited cancer genes with loved ones. There's a link right now to register in the chat box if you're interested. Again, please remember that Sharsheret is here for you and your loved ones. Sharsheret provides emotional support, mental health counseling, and other programs designed to help you navigate the cancer experience or the pre-cancer experience. All are free and completely confidential, and you can reach us at the email that I just saw pop up in the chat box. I'm also going to ask my colleague Bonnie to put the link to the evaluation in one more time. And thank you all for being with us tonight. Again, if you are staying on for the Embrace breakout, just stay put exactly where you are. And for the rest of you, have a lovely evening. Good night.